Hello, my name is Dr. Melanie Bourgeot, and I am now a soft tissue pathology fellow at the University of Colorado. For those who don't know, July is the start of the academic year for residency and fellowship programs, so I figured now would be a great time to do another New Resident Unknowns video. Last year, I focused on deep soft tissue tumors, so this time around I'll discuss 3 entities that tend to arise in the skin and subcutaneous fat. Also, to fight a certain stereotype about soft tissue tumors, none of the cases I'll be discussing are spindle cell lesions. However, if you are interested in that, you can check out my last video series. As usual, if you would like to preview these cases beforehand or review them afterwards, you can find those links in the video description. Now let's get started. Case number 1 is a lesion on the oral mucosa of a 52-year-old male. To start things off, I want to talk briefly about how to approach unknowns cases and describe what you see on a slide. If your program is anything like mine, you'll be doing this a lot as first years, and I recommend coming up with a systematic approach. It's a good way to organize and communicate your thoughts, and you'll be less likely to avoid missing something important. The first and the best place to start is at low power. Things to describe should include location, relation to normal tissue, and initial impression, such as color, cellularity, and the presence of hemorrhage or necrosis. For this case, we have a lesion located just below the epithelium, which seems acanthotic or thickened. This could be due to external trauma or a reaction to the underlying tumor. Below the mucosa, there is not much non-lesional tissue to assess, since the tumor extends to both the peripheral and deep section edges. Because of this, we also cannot determine the size or depth of the lesion. The tumor itself appears to be composed of vague nests of eosinophilic to amphiphilic cells. Between the nests are bands of bright eosinophilic material, possibly collagen. I'm also going to note that the area at the bottom right looks a little bit different, and there appears to be clefting around some structure, so I'll make sure to check out that area when we move in closer. At medium power, you'll want to confirm your low power impressions and add more detail regarding the architecture and cytology of the lesion. Returning to our case, I can see that my initial impression of nests of pinkish cells and intervening collagen stroma was correct. I'll also add that these cells have abundant granular cytoplasm and small round nuclei, and that I also can't really appreciate the borders between the cells. Moving to the area I was interested in on low power, I can see that the structures I saw were actually bundles of skeletal muscle. Not only that, but the cells are infiltrating between the skeletal muscle bundles and also around nerves. Finally, at high power, I'll confirm what I saw at medium power and assess the nuclear and cytoplasmic features, including the presence of atypia, mitotic activity, and necrosis. For example, I can see that tumor cells here have abundant, finely granular eosinophilic cytoplasm, and I can also appreciate some larger granules that separate themselves from the smaller granules, almost like a force field or a halo. The nuclei are round to oval with some size variability, but nuclear features are uniform, with vesicular or bubbly chromatin and a central punctate but not prominent nucleolus. Lastly, I don't see any mitotic figures or necrosis. Once you're done describing what you see, the final step is to say what you think the diagnosis is, or give a differential, and discuss any immunohistochemical stains or molecular testing that you would order to confirm your diagnosis. In this case, I would say that I feel pretty confidently that this is a granular cell tumor. As for the differential, there isn't really much else this could be, especially if I knew the patient age and tumor location. But I would order an S100 and or SOX10 to confirm. And what a surprise! This is indeed an example of a granular cell tumor, a largely benign tumor thought to be of Schwannian origin. It can occur in a wide variety of locations, including skin and soft tissue, oral mucosa, and less commonly visceral sites. As the name implies, tumor cells have abundant eosinophilic granular cytoplasm that is PASD positive, so PAS diastase resistant. The large granules are called pustulo-ovoid bodies of Milan, which is definitely something your attending will ask if you come across one of these. By immunohistochemistry, cells are positive for S100, SOX10, MITF, and CD68. Most cases are also positive for nuclear TFE3, inhibin, and calretinin. An important pitfall is that some cases can induce pseudoepitheliomatous hyperplasia in the overlying epithelium, which can mimic squamous cell carcinoma, especially in small superficial biopsies. For example, if you got the very top of the specimen, like right here, you might see the thickened epithelium and the parakeratosis and maybe think this is a squamous lesion and overlook these unusual cells in the dermis. Another pitfall for granular cell tumor is its infiltrative growth pattern. As I showed earlier, it surrounds skeletal muscle fibers and even nerves. However, this is not true perineural invasion. It should not cause concern for malignancy. Speaking of which, although the vast majority of granular cell tumors are benign, atypical and malignant cases can occur. Atypical features should be diffusely present and include nuclear pleomorphism, prominent nucleoli, high nuclear to cytoplasmic ratio, spindle cell morphology, a mitotic rate greater than 2 per 10 high power fields, and necrosis. Here is an example of a granular cell tumor that arose in the vulva. Clinically, this was thought to be a cyst, which, trust me, is not the first or the last time you'll see that on the requisition sheet of something that is clearly not a cyst. Interestingly, this case is very well circumscribed and even partially encapsulated. Before I move on to the next case, I want to briefly mention non-neural granular cell tumor, in particular congenital granular cell epulis, which occurs on the anterior alveolar ridge of the oral mucosa in predominantly female newborns. Cells are indistinguishable from granular cell tumor, but do not stain with S100 and other neural markers. In addition, the overlying mucosa is atrophic, not hyperplastic. These tumors are always benign and often regress by the time the patient is a year old. Case number 2 is a tender nodule arising on the arm of a 30-year-old female. At low power, I see that this is a very blue lesion that is multilobular and encapsulated. I can also see some adjacent adipose tissue, which makes me think that we might be in the subcutis. Taking a closer look, there are also pink areas of hyalinization, as well as small blood vessels. Most of the lesion is composed of nests and cords of uniform small round cells, with inconspicuous slit-like capillaries in between. At high power, these cells have scant amphiphilic cytoplasm with distinct cell borders. The NC ratio is high, and nuclei are round and centrally located, with fine chromatin and one or more punctate nucleoli. In some cases, this produces a salt and pepper-like chromatin pattern. This is an example of a glomus tumor, a usually benign neoplasm of modified perivascular smooth muscle cells. Most cases arise in the skin as a tender, bluish-colored lesion. They are most common in young women, where they have a strong propensity to be subungual, which means under the nail. All glomus tumors are composed of a variable amount of glomus cells, blood vessels, and smooth muscle, and there are 3 morphologic subtypes based on the relative amount of each of these components. The case I just showed you is an example of solid glomus tumor, which is the most common subtype and accounts for about 75% of cases. It is predominantly made up of glomus cells, and vessels are small and infrequent, with rare smooth muscle cells. Glomangioma, the second most common subtype, makes up about 20% of cases. Glomus cells are still a significant portion of the tumor, but there are also numerous large, dilated vessels. The third and final subtype, glomangiomioma, is very rare. It looks similar to glomangioma, but with the addition of a distinct smooth muscle component. Here is an example of a glomangioma of the stomach. You can see that there are numerous, often ectatic vessels, and the glomus cells tend to form this layer surrounding them. If you just had that, you would call it a glomangioma, but if we look at this area right here, there is a proliferation of spindled smooth muscle cells. In terms of its immunophenotype, glomus cells are positive for SMA, calponin, and H-caldesmon, with focal CD4 staining in a subset of cases. Interestingly, a subset of gastric glomus tumors demonstrate at least focal positivity for synaptophysin. Last but not least, rare atypical or malignant examples have been described. Features to look out for include nuclear atypia, increased mitotic activity, and atypical mitotic figures. Cases with only nuclear atypia are designated as symplastic glomus tumor and have the same prognosis as a conventional benign glomus tumor. Case 3 is a pedunculated mass arising on the upper back of a 15-year-old male. At first glance, I see that this lesion has an exophytic, almost dumbbell-like growth pattern. It is well circumscribed and unencapsulated and extends into the mid-dermis. There's a large vessel in the deeper dermis, which I could presume is associated with the lesion. The tumor itself appears to contain numerous blood-filled spaces of varying sizes. These may be blood vessels or pseudocysts. Moving to medium power, I can confirm that these are indeed blood vessels. We have larger ones in the center of the lesion, and around them are numerous capillaries. Some are small, while others are larger and more dilated. Lastly, at high power, I see that the stroma is variably hyalinized with scattered chronic inflammatory cells. Lining the capillaries are a single layer of endothelial cells. These are largely flat, with small dark nuclei and minimal cytoplasm. If I scanned around enough, I could probably find some that are a little larger and protrude a bit into the vascular lumen, but I wouldn't see any atypical cytologic features. This is an example of a lobular capillary hemangioma, a benign vascular lesion that most commonly arises in the head and neck, including mucosal sites. A minority of cases are associated with trauma or pregnancy. These lesions usually do not spontaneously regress, except in some pregnancy-associated cases, which resolve following delivery. Sometimes these are called pyogenic granulomas, which I'm not a fan of because it is neither of those things. In contrast, lobular capillary hemangioma is a perfect name. It's comprised of capillaries, arranged in lobules, around large feeder vessels, and it's benign. Other histologic features to look for include exophytic or pedunculated growth, with an epidermal collarette. This is the narrowing of the epidermis around the lesion you see here, like a collar around the neck of the tumor. Due to its growth pattern, the overlying epidermis is often eroded or ulcerated. In young children, one lesion that may enter the differential is infantile hemangioma. If these become irritated and inflamed, they can look very similar to lobular capillary hemangioma. In such a case, immunohistochemistry for GLUT1 can help. The endothelial cells of infantile hemangioma are GLUT1 positive, which is not seen in the endothelial cells of lobular capillary hemangioma. One pitfall to be aware of is that red blood cells are also positive for GLUT1, so it is important to take a closer look to confirm that the staining you see is actually in the endothelial cells and not in red blood cells stuck to the vessel wall. And that's all I have for now. Please like and subscribe, and for even more educational pathology content, you can follow me on social media, as well as check out my Mega Index, which has links to all my posts and videos. Thanks for watching!